الماوس احطها هنا.
هو بس اليو اس بي من هنا فهو يعرف يمتد.
لا لا مش مشكلة. Thank you very much, Madam Chair Lady, Mr. Chairman. Allow me first to thank Professor Ali Al-Aghouri as well as Professor Tamir Shirbini. I always admire this
دكتور سمير
conference.
التليفون اللي ده مش الصوت
كده بدينا من التليفون تاني كده سامعني؟ سامعني؟ فين هو؟ ده اهو ده احسن يعني؟ Allow me first to thank Professor Ali Al-Aghouri and Professor Tamir Shirbini. I always admire this conference, very successful ThyroAlex 15, and you should celebrate for the number 15. Inshallah 25 or 50 يبقى قريب إن شاء الله. When Professor Alia actually told me to prepare this subject, although it appears complex, weary, but actually this brought me back to 30 years ago when we had this consultation. This patient presented with bilateral proptosis, as you see. He was brought from the ophthalmology clinic, and this is a lateral view of his eyes, evident proptosis. ممكن نقفل الباب لو سمحت يا أستاذ أحمد. أستاذ أحمد خليك. And as you see, he's got, and of course, you will think that we are in a ThyroAlex, that this is Graves' ophthalmopathy. Is it truly Graves' ophthalmopathy? And when we have done CT at that time, this is 1993, 30 years ago, and we discovered, as you see, this was bilateral lymphoma of the orbit causing the proptosis. And as you know, and as I explained, that lymphoma is producing also some monoclonal antibodies. And this is the usual in patient with Graves. We get thickening mainly of the medial recti. This is a normal recti. And also this brought back to 2008, when our group, guided by Professor Suhail Saeed, as we had in collaboration with Dr. Mohammed Ghittani, and this was the MS thesis of Dr. Manal Abul Fadl, who is the dynamo of this conference. And we actually, I presented this in Rio de Janeiro in Brazil for the International Congress of Endocrinology, and we have discovered that 1/4 of our patients with hepatitis C, they do have actually thyroid problems. And in the Italian, maybe 6 or 8 years ago, they published this paper linking the hepatitis C virus to the thyroid problems. And as you know, hepatitis C virus can cause what we call mixed cryoglobulinemia, which is also monoclonal antibody. So when Professor Ala mentioned that, I thought, oh, we have got several cases of monoclonal antibody disease in relation to this. So this was a very interesting topic. Thank you, Professor Ala, for this choice. And in the next 60 minutes, I will go through the path. I will give a short introduction, then go through the different items of the relation between the monoclonal antibodies and the thyroid gland. First, the introduction, the monoclonal antibodies are a group of antibodies produced by one clone of plasma cell or beta cell. This is monoclonal antibody. And they have specific target, as you see. They're very sensitive and specific. And now, this term was actually coined in 1975 by Dr. George Kohler and Cesar Milstein. This is in Cambridge. And actually, this monoclonal antibody nowadays is used for diagnosis as well as in treatment. Actually, 1/3 of the new treatment of different conditions, cancer, autoimmune, inflammatory, cardiovascular disease, even lipids, you know, the PCSK1 antibody, this is monoclonal antibody. Migraine, the new antibody for migraine. All these are the MAB group. So remember, anything ending by MAB, this is a monoclonal antibody. So The second thing, and monoclonal antibodies are abnormally produced in certain pathologic conditions. You can see the famous one is multiple myeloma and Waldenström globinemia. This is maybe rare, but multiple myeloma, we are seeing a lot of multiple myeloma nowadays. This can affect also the thyroid, I will explain to you. Other conditions, like you can see that the amyloidosis, and as I explained, the mixed cryoglobulinemia with hepatitis C. Another more recent term is MGUS. I'm going to explain maybe later, inshallah. The second part of the pass is how can the monoclonal antibody be useful for diagnosis of thyroid and disease. You know, in Hashimoto, the anti-thyroglobulin autoantibody and the anti-TPO are very diagnosis. Actually, these antibodies are monoclonal. And most recently, you remember the TRAP, specific for Graves' disease. Now there is a novel third generation monoclonal antibody for the detection of the TRAP. So this is, again, a relation between the monoclonal antibody and thyroid. The second relation is that can be used, the monoclonal antibody, for treatment of thyroid disease. Yes, indeed. And this was 4 years ago. The question, is there potential for approval for monoclonal antibody to treat thyroid associated ophthalmopathy? Actually, 10 years earlier, there was a very interesting study in which they tested the rituximab for treatment of Graves' ophthalmopathy. This is the anti-CD20 monoclonal antibody. But more recently, we've got, this is the data, it was more effective than methylprednisolone. But more recently, we've got another mAb, which is a teprotumab. This is a monoclonal antibody against insulin growth factor receptors. Insulin growth factor receptors are present in the orbital tissue. And when the antibody will bind to this receptor, this will lead to Graves' ophthalmopathy. And actually, when they tested this medication, was now approved in the USA, you can see there were marvelous improvement in the not only in proptosis but also in the in orbital pain and in the eyelid erythema and conjunctival redness. And this was quite effective. And if you read the data, and it was very interesting study by George Kahali. George Kahali is #1 in the use of teprotumab all over the world in Graves' ophthalmopathy. He's a German, not USA. When I met him a week ago, I asked him, what's your experience with that? What is the price in Germany? He told me, Samir, you know, this drug is not present in Germany even. So I was astonished because he did all the results and they don't have the drug in Germany because it's quite expensive. And I don't know if you're going to have it one day for our patient, but it seems very, very effective. The third part of my presentation is about monoclonal antibody causing thyroid disease. So the first part is monoclonal antibody for the diagnosis. Number 2, monoclonal antibody in thyroid disease treatment. And now, can monoclonal antibody therapy can lead to thyroid disease? Let's go to a very interesting paper. This paper, one of the monoclonal antibody here, it was the alemtuzumab, used to treat patients with MS, multiple sclerosis. And what they did show that this was associated with different clinical problems with thyroid. It can occur with the form of Graves' disease, thyroiditis, subclinical thyrotoxicosis, and hypothyroidism. So this group of drugs can be associated. And another drug is the nivolumab. Remember, mAb is monoclonal antibody used to treat renal cell carcinoma, is associated also with thyroid. And there are others. So whenever in the clinic, you've got patient with thyroid treatment, ask him what thyroid disease, ask him what type of treatment are you taking, and look for this new medication. Sometimes I don't know even the name of the drug. So tell me, give me the brochure, and I open my phone to look for this fancy drugs for hematologic malignancy and all sorts of malignancy. The first part of my past is the spurious or false thyroid results by monoclonal antibody. And you remember my talk in ThyroAlex 13. when I presented that how can certain drugs interfere with the assay. And this was a publication by Antopolo, this was a few years ago. They presented a 54-year-old woman who presented with fatigue. And the lab showed the TSH was normal, T3 very, very high, T4 normal, free T4 normal, and T3 uptake was normal. So this cannot be expected because if the T3 is really high, the TSH should be down. So this was a spurious false result because the patient was taking one of the monoclonal antibody. And this is a mechanism I explained 2 years ago because this antibody can interfere with the assay. A simple assay interference, simple assay. So once you look for that, ask the lab to do it by another method. The last part of my talk is about the diseases associated with excessive monoclonal antibodies leading to thyroid affection. And this is the main bulk of my presentation. And I will start by the multiple myeloma. Multiple myeloma, as you remember, this is a clonal malignancy of the plasma cells and excessive amount of abnormal monoclonal antibodies. And multiple myeloma can be associated with autoimmune thyroid disease. This is number one. Multiple myeloma associated with autoimmune thyroid disease. Number two, the drug they are using now for treating this patient, the lenalidomide, which is a derivative of thalidomide. This lenalidomide, very effective for multiple myeloma, can also lead to autoimmune thyroiditis. Third is sometimes the multiple myeloma can present with a thyromegaly nodule, like this patient with right thyroid nodule. This is CT, this is a trachea, right lobe nodule. And you can see this nodule was actually full of plasma cell. This is called plasmacytoma. And plasmacytoma can be present in 1/10 of the patient as diagnosis, but very, very rarely can be the only presentation without affection of the bone marrow. So remember plasmacytoma. And this is diagnosed, of course, by doing biopsy. Of course, if you operate on this patient, you'll get the diagnosis retrograde. But if you diagnose it pre-operative, no need for surgery. Another important thing is that patient with Hashimoto, they have a tendency to have multiple myeloma. So remember this. Patient with Hashimoto, they can get higher rate of papillary carcinoma, higher rate of lymphoma, and unfortunately, higher rate of multiple myeloma. And this was a couple of publications. They discussed this association, the association between autoimmune disease leading to multiple myeloma. Another interesting association is what we call IgG4 multiple myeloma. IgG4 was coined 10 or 15 years ago, and this disease is excessive amount of IgG4 can lead to enlargement of thyroid and can be associated also with multiple myeloma. Another disease is the amyloidosis. You can see this one of the patient, and in the literature, you can see that he was trying to look up and to the left. He cannot move the left eye because there was infiltration and thickening of the left inferior rectus. And this seems like Graves, but this is not Graves. This is actually primary amyloidosis affecting the eye. Another lady who was 6 years presented with a recurrent thyroid problem. And with the goiter, they did surgery, and the frozen section showed that, you see, this bulk is amyloid tissue. And when the surgeon sees that, means that the patient has got query medullary carcinoma of thyroid. And actually, she was diagnosed query, but the final diagnosis was amyloid goiter. So we have to remember that the amyloidosis can affect whether primary or secondary, as you see, secondary to chronic inflammatory condition like inflammatory bowel disease, rheumatoid, and so on, but can be also primary, what we call the AL type of amyloidosis. And this is diagnosed, I mean, you've got a goiter, you have to suspect it by the abnormal feature of a patient, and then this diagnosed either by biopsy, sometimes difficult, but mainly is by the clinical picture. Thirdly is lymphoma. Lymphoma can affect also the thyroid. 5% thyroid neoplasm are due to lymphomas, usually occur in ladies, middle-aged, and on a background of CLT, Hashimoto. So remember, Hashimoto can lead to lymphoma, multiple myeloma, but you shouldn't scare your patient. But if the patient asks, because they read it in the net, do I have problem with CLT leading to so-and-so? You say, yes, but this is not common, because the risk of having lymphoma in patients with Hashimoto is 40 to 80-fold. And it presents with a rapid enlargement, diffuse or not their gorge. So remember, this is rapid. Within few months, all the publication, within few months. And a fine needle aspiration may be helpful. US ultrasound is not very helpful. On isotope is cold, but it depends mainly on the clinical picture, sometimes on true cut biopsy. And this is one of the patients with the lymphoma. This is the CLT. You can see the foci of inflammatory cells, but this is the lymphoma invading the thyroid follicles. So this is different. Lastly, sometimes patients with monoclonal gammopathy can be associated with thyroid cancer, like this publication. These are rare incidental cases, papillary carcinoma, another report of monoclonal antibody due to Waldenström macroglobulinemia leading to medullary carcinoma. This is very, but you have to know about this term. And thanks to Professor Alia, because she raised this very important topic of the relation between monoclonal antibodies and thyroid. I will end by this term, MGUS, what we call the monoclonal gammopathy of undetermined significance. This is a new term to me, at least. And this was, although it was coined in 1978, because we are endocrinologists away from hematology. And this is a form of pre-malignant clonal disorder with abnormal M protein diagnosed in the blood test. And usually it is not associated with multiple myeloma or Waldenström. So they have the plasma cells is less than 10%. The monoclonal protein is less than 3 grams, unlike the multiple myeloma, with no bone disorder, no anemia, no renal affection like multiple myeloma. So we have to think about this. And two rare syndromes, but remember, maybe for MD candidate, they have to remember the POEM syndrome. This is P for the polyneuropathy, O for organomegaly, E for the endocrinopathy. That's why I'm mentioning here. M is for monoclonal antibody, and S for skin affection. And you can see that the endocrine affection can be in the form of overt or subclinical hypothyroidism, can be in the form of adrenal insufficiency, and also in the form of hyperprolactinemia, and lastly in the form of hypogonadism in men or women. So we have to remember these POEMs, although it's rare. Another more interesting and more rare is the scleromyxedema. Scleromyxedema. This is a picture of one of patient myxedema. There is generalized papular and sclerodermoid eruption, and this is in the absence of thyroid. So they look like thyroid, but they are not thyroid. And this is the picture of one of the patient published. And it looks like, remember, like leprosy. In the old time when you used leprosy, leonine face. And actually, this is not leprosy. This is the scleromyxedema. So remember, monoclonal antibody and thyroid. So at the end, Madam Chair Lady, Mr. Chairman, ladies and gentlemen, in the past, I show you a short introduction. The monoclonal antibodies are there. We have to know them. Monoclonal antibodies are useful for the diagnosis of thyroid disease, useful for the treatment of thyroid eye disease, and sometimes the use of monoclonal antibody for treatment can lead to thyroid disease, and also some gammopathy can lead to abnormal false thyroid function. And lastly, remember, the gammopathy like multiple myeloma, Waldenström macroglobulinemia, hepatitis C virus, amyloidosis, lymphoma can also affect the thyroid. And thank you very much for your attention.